Hello, and thank you for listening to our Dollars and Donuts presentation featuring a Medicaid overview. My name is Louis Haley.
And my name is Eric Richardson.
And today we will run through a high-level overview of Medicaid, which is an issue that will likely be discussed in earnest this session and over the next few years. Medicaid, also known as medical assistance, is a joint federal and state program created under the Federal Social Security Act. It is an entitlement program, meaning anyone who applies that meets federal and state eligibility criteria must be served. Medicaid must be available statewide to all clients, no matter where they live. It is managed by the Centers for Medicare and Medicaid Services on the federal level and by the Department of Health and Human Services on the state level. Medicare and Medicaid are sometimes confused. Medicare is administered and funded at the federal level, while Medicaid is administered at the state level and is funded through state and federal appropriations. Medicare beneficiaries are mostly people aged 65 and older and people under 65 with certain disabilities, while Medicaid focuses on mostly low-income adults, pregnant women, children, and some disabled and elderly folks. Medicare coverage is consistent nationally given federal administration and is the primary payer when a beneficiary is eligible for both Medicare and Medicaid. Medicaid coverage varies by state and is the payer of last resort, meaning that Medicaid only pays for covered care and services if there are no other sources of payment available. You'll often hear the acronym FMAP in relation to Medicaid. FMAP is the Federal Medical Assistance Percentage, which is the percentage of federal payment of Medicaid expenditures. There is a complex formula used to determine how much the state pays for Medicaid, which is based on the state's per capita income compared to the nation's per capita income over a 3-year average. The formula considers total annual personal income in the state and divides that number by the total population in the state. Federal fiscal year 2026 rates are based on per capita personal incomes for calendar years 2021 through 2023. In federal fiscal year 2026, set to begin October 1st, 2025, the highest state FMAP rate is Mississippi at 76.9%, which means that the federal government pays for 76.9% of all Medicaid expenditures in a fiscal year, while Mississippi needs to pay 23.1% of all expenditures. The lowest FMAP rates are at 50%, the lowest allowed by law, and shared by 10 states in fiscal year 2026. Iowa's federal fiscal year 2026 FMAP rate is 62.7%. This is a 0.55% decrease from the federal fiscal year 2025 FMAP rate. As you can see in the graph, Iowa's FMAP rate was relatively stable from 1992 until about 2010 when it began dropping. After 2016, the rate began rising again, which meant that Iowa's per capita income measure was growing slower compared to other states. Federal fiscal year 2025 was the first time since 2016 that the rate fell. The FMAP decreased again in federal fiscal year 2026, indicating that Iowa's per capita income was doing better since 2021 compared to other states. This FMAP rate does not include any enhanced FMAP associated with the federal public health emergency, which ended on April 1st, 2023. During the public health emergency, Iowa received a temporary 6.2% increase in the FMAP rate, which was scaled down slowly throughout the rest of the calendar year 2023 after the public health emergency ended. To be eligible for Medicaid, you must be categorically eligible unless you are participating in the Iowa Health and Wellness Program, or IHOP, which is the Medicaid expansion under the Affordable Care Act. This means that to be eligible, one must fall into a specific category, such as a child, pregnant woman, family with a dependent child, an elderly person, a blind person, or a disabled person. You must provide citizenship and provide identification. This chart illustrates eligibility for potential Medicaid beneficiaries. In calendar year 2025, the federal poverty level for a family of 4 is $32,150. The FPL percentage for various beneficiaries and programs are listed in the chart. The greatest allowances for Medicaid enrollment are for children under age 1 and pregnant women. Note that the Children's Health Insurance Program in Iowa, known as Hawkeye, has a greater FPL allowance compared to the regular Medicaid program and is highlighted in the chart. Here are the calendar year 2025 federal poverty level limits as percentages of the FPL, to illustrate the ranges based on percentage and family size. As of December 2024, there were 417,485 individuals enrolled in the Medicaid program in Iowa. This includes 240,000 children, 67,000 adults, 34,000 elderly, and 76,000 disabled. This slide illustrates the 2-year trend of Medicaid enrollment. The orange line in the middle represents total enrollment, with the bars representing the different categories of beneficiaries. Enrollment was moving upwards until May 2023 during the public health emergency, when the state was not allowed to disenroll anybody from Medicaid in exchange for the enhanced FMAP. Starting in May 2023, Iowa began disenrolling anybody who did not meet income eligibility, which is why the total enrollment line slopes downward. Since June of 2024, enrollment has remained consistent.
This slide details the changeover in Medicaid from a fee-for-service model to a managed care model. Prior to April 1, 2016, Iowa Medicaid operated under mainly a fee-for-service model. In a fee-for-service model, providers are paid for each service they provide, such as an office visit, blood test, or surgery. Iowa Medicaid previously handled over 23 million claims per year and contracted with over 38,000 providers, so the administrative burden was enormous. Starting in 2016, coverage of 94% of Medicaid clients was transferred to the management of 3 managed care organizations, or MCOs. Currently, WellPoint in Iowa, formerly AmeriGroup, Iowa Total Care, and Molina Healthcare of Iowa. MCOs are insurance companies that have goals of managing cost and utilization and improving quality. MCOs rely on capitation payments from the state and accept a set per member per month or capitation payment for services. This provides the state with more certainty in regard to Medicaid expenditures. Some examples include a healthy child between ages 1 and 4. The MCO receives $208 per month for her care, while the MCO receives $4,554 per month for grandma's care in a nursing home, which is typically very expensive. Every year, the MCOs contract with the state any potential increases in capitation payments. Iowa is required by the federal government to provide a minimum set of benefits in order to receive federal match funds. These services include inpatient and outpatient hospital services, physician services, transportation to medical care, nursing home care, home health care, family planning services, laboratory and X-ray services, and early periodic screening, diagnosis, and treatment services, along with other services. Iowa has also been given the flexibility to provide additional services to clients. Some of the optional services available include intermediate care facilities, pharmacy benefits, home and community-based services or HCBS waivers, mental health and substance abuse services, habilitation services, hospice, dentists, case management, and other services. I'll talk about the HCBS waiver program because it is a large part of Iowa Medicaid. Iowa has 7 different HCBS waivers, which are available to clients who otherwise would require care in an institution but can remain in their home. Waivers include the Health and Disability Waiver, which provides services for blind or disabled persons under the age of 65, the AIDS/HIV Waiver, the Elderly Waiver, the Intellectual Disabilities Waiver, the Brain Injury Waiver, the Physical Disability Waiver, and the Children's Mental Health Waiver, which provides services for children diagnosed with a serious emotional disturbance. HHS has proposed an HCBS waiver redesign that would drop the number of waivers from 7 to 2 and would make the waivers based on age rather than diagnosis. One waiver would be for children and youth ages 0 through 20, and the other would be for adult and aging, age 21 plus. The waivers would mostly cover the same groups of people, including intellectual disability, brain injury, AIDS, HIV, physical disability, including blindness, and a new covered group in developmental disabilities. The only difference between the waivers in terms of groups served is that the children and youth waiver would serve youth with serious emotional disturbance, and the adult and aging waiver would serve the aging population. The HCBS waivers provide individuals access to a variety of different supplemental services. Some of the more common waiver services include adult daycare, consumer-directed attendant care, home and vehicle modification, home health aides, supported community living, respite care, transportation services, and a consumer choice option. Next, I'll move on to the Iowa Health and Wellness Program known as IHOP. This is the Medicaid expansion as part of the Federal Affordable Care Act. The program covers adults ages 19 through 64 with income between 0 and 133% of the FPL who are not otherwise eligible for Medicaid, Medicare, or affordable insurance. Clients are enrolled with an MCO and have access to the same provider network as the regular Medicaid program. Enrollees are eligible for 12 months with income re-verified for eligibility near the end of the 12-month period. For IHOP, there are no co-payments except $8 for using the emergency room when it is not a medical emergency. There are no monthly contributions or premiums in the first year, and no contributions after the first year if the member completes preventative services and/or wellness activities. There are monthly contributions only for adults with income at 50% of the FPL or above if preventative services or wellness activities are not completed. As of December 2024, there were approximately 181,000 individuals enrolled in the IHOP. The program had seen the same surge in enrollment due to the disenrollment requirements related to the 6.2% enhanced FMAP maintenance of effort requirement as Medicaid. Since the PHE ended on April 1st, 2023, the program has seen decreased enrollment of approximately 91,000 individuals.
Overall expenditures for Medicaid and IHOP in fiscal year 2024 totaled $8.489 billion. This included approximately $5.9 billion in federal payments, $2 billion in state funds, and $600.8 million from other funds, such as hospital fees. Top expenditure categories include hospitals, nursing facilities, intermediate care facilities, HCBS waivers, mental health services, and physicians. This graph looks at fiscal year 2024 Medicaid enrollment and expenditures. 57.7% of enrollees were children, with smaller percentages for the disabled, adults, and the elderly. On the expenditure side, approximately half were due to the disabled, with smaller percentages for children, the elderly, and adults. Interestingly, while the disabled and elderly account for only 24.9% of enrollees, they accounted for 67.6% of expenditures in fiscal year 2024. So what drives Medicaid costs? First is enrollment, which grew extensively during the pandemic before disenrollment started in May 2023. Then comes utilization in services and trends in the healthcare system. Another factor is changes in federal law, including changes in the FMAP rate and Medicare Part D payments. Specifically, with Medicare Part D, if Medicare does not cover some drugs, benefits are reduced, or if the cost of Medicare Part D increases, this has a spillover effect onto Medicaid. There is also a Medicaid supplement for those low-income seniors unable to afford Medicare premiums. Any changes in state law also affect Medicaid, including new services, eligibility changes, and provider rate reimbursement changes. What are the legislature's responsibilities? The legislature is allowed to set provider rates, and every year provider rates are set in the Health and Human Services Appropriations Bill. During the 2024 session, that was House File 2698, and beginning around page 14 of that bill, there are numerous clauses outlining provider rates for fiscal year 2025, most of which were status quo from fiscal year 2024. The legislature also decides the amount, scope, and duration of optional services and sets rules, regulations, and processes not governed by the federal government such as prior authorization for services or additional provider audits. The legislature may also change eligibility, premiums, or enrollment fees, or impose more restrictive eligibility procedures except when prohibited by federal law. We also want to touch on some recent legislation that has been passed regarding Medicaid. First, Senate File 2251 from last year extended postpartum Medicaid coverage from 60 days to 12 months after a pregnancy ends, and amended the FPL eligibility thresholds for infants and pregnant women from 375% to 215%. The act required HHS to submit a state plan amendment to CMS to approve the changes, and the changes were just recently approved on January 7th. The implementation date has not been confirmed yet, but when it is implemented, we are expecting to see an average decrease of 1,700 people from Medicaid in future years, including 1,300 adults and 400 infants. And we are expecting to see Hawkeye enrollment increase by 1,100 infants who were previously on Medicaid. Additionally, Senate File 494 was passed 2 sessions ago and enacted various changes related to public assistance programs, including Medicaid, the Supplemental Nutrition Assistance Program, the Family Investment Program, and the Children's Health Insurance Program. These changes include new income thresholds and enrollment procedures for applicants, new state and federal information review by HHS, a new computerized system to provide identity verification and authentication, and new communication protocols for applicants. In fiscal year 2024, state expenditures for the implementation of Senate File 494 totaled $256,939. HHS submitted and received federal approval for planning advanced planning documents for federal fiscal year 2024 and 2025. These documents allow HHS to claim federal Medicaid, CHIP, and SNAP match for costs to support planning activities related to the Act. Federal reimbursement for related expenditures totaled $93,182 at the close of federal fiscal year 2024. There were no FTE position hires related to Senate File 494 in fiscal year 2024, but the new requirements are expected to increase FTE positions in the coming years. Lastly, House File 685 established a new tax on MCO premiums received and taxable that became effective January 1, 2024. The tax is paid by MCOs on or before March 1st of the year following the calendar year when the tax is due, with the first due date in fiscal year 2025. The tax is federally reimbursed to the state through Medicaid FMAP rates, with the MCOs reimbursed for their share of the tax. Regarding the state Medicaid forecast, the Legislative Services Agency, the Department of Health and Human Services, and the Department of Management meet quarterly to discuss estimated Medicaid expenditures and agree on an estimated need or surplus for current and future fiscal years. We met on December 13th and agreed to the following. For fiscal year 2025, the group estimate was that Medicaid will have a surplus of $124.7 million, which includes capitation rate increases and an anticipated transfer to the Children's Health Insurance Program of $5.3 million to cover an estimated shortfall in fiscal year 2025. For fiscal year 2026, the group estimate was that Medicaid will have a deficit of $116.9 million, which does not include capitation rate increases. The Legislative Services Agency publishes a summary of the forecast meeting, which you can find at the link in the presentation. Another big health insurance program is the Federal Children's Health Insurance Program, or CHIP, which was established by the Federal Balanced Budget Act of 1997 to provide health care coverage to uninsured, low-income children under age 19 who live in families with incomes up to 200% of the federal poverty level. Iowa implemented CHIP through a combination of Medicaid expansion and a new program called Healthy and Well Kids in Iowa, or Hawkeye. CHIP covers children with family income up to 300% of the federal poverty level, with cost sharing for families with incomes between 200% and 300%. Children are provided a variety of medical benefits, and there is a dental-only option for children who have private health insurance but limited or no dental coverage. CHIP plans are available through WellPoint, Molina, and Iowa Total Care, just like Medicaid, but the dental-only plans are provided through Delta Dental and MCNA Dental. CHIP is not an entitlement program and is funded with a set allotment of funds for each state. Iowa receives an enhanced FMAP matching rate for CHIP of approximately 75% annually. Regarding the CHIP forecast, LSA, HHS, and DOM also met on December 13th to discuss estimated CHIP expenditures and agreed to the following. For fiscal year 2025, the group estimate was that CHIP will have a deficit of $5.3 million, which includes capitation rate increases. For fiscal year 2026, the group estimate was that CHIP will have a deficit of $17.4 million, which does not include capitation rate increases. Prior to fiscal year 2025, Medicaid, CHIP, and the State Supplementary Assistance Program each had their own general fund appropriations in the annual HHS appropriations bill. But due to House File 2698 from last year, the three programs were combined into one medical assistance appropriation that provides separate allocations for each. House File 2698 appropriated a total of $1.651 billion for medical assistance for fiscal year 2025. LSA also publishes various articles and reports on Medicaid, which can also be found here in the presentation, and our contact information can be found below on slide 32. Thank you for listening.